Good morning, and welcome to our Alaska Collaborative on Health and the Environment teleconference with Dr. Ruth Etzel, who will be discussing evidence-based advocacy for children's environmental health. My name is Diana DeFazio, and on behalf of Alaska Community Action on Toxics, I'll be facilitating today's call. CHE Alaska is a regional partnership group of the National Collaborative on Health and the Environment. CHE Alaska aims to advance knowledge and effective action to address growing concerns about the links between human health and environmental factors. You can find more information on the following websites: www.akaction.org and www.healthandenvironment, and is spelled out, .org. This call will last 1 hour, and there will be a time for discussion and questions at the end. Everyone who signed up for the call by yesterday afternoon should have received an email from me with a link to Dr. Etzel's presentation slides. If you haven't done so already, please take a moment to download the presentation, which can also be found by going to our homepage at akaction.org and clicking on the title of today's call, which is on the upper left of the page. So anybody who signed up today, just go to our homepage to get access to those slides. Before introducing Dr. Etzel, I want to give you a brief update on the status of the Toxic-Free Children's Act, or SB 151, an important bill sponsored by Alaska Senator Donnie Olson and being considered by the Alaska State Legislature. This bill would protect Alaska's most vulnerable citizens, our children, from harmful chemicals in everyday products. The bill includes a phase-out of toxic tris flame retardants, which are known to cause cancer, neurological defects, and reproductive harm. In the 1970s, chlorinated tris was taken out of baby sleepwear due to its carcinogenicity. However, tris flame retardants are still being used in baby and children's products, including foam-filled furniture, nap mats, nursing pillows, car seats, and play tents. Thanks to support from Alaskan moms, firefighters, nurses, and other Alaskans, the Senate Health and Social Services Committee passed the Toxic-Free Children's Act out of their committee. Now we need a Judiciary Committee hearing scheduled to ensure the bill is passed this session. We've come this far, and we don't want to let the Toxic-Free Children's Act get tabled. So for the Alaskans on the call today, we ask you to please contact senators of the Judiciary Committee and ask them to schedule a hearing. Making this request is easy on our website at akaction.org, where you can submit a form to members of the Judiciary Committee. And I'll also be sending an email with a direct link to the form page after the call ends. Now it is my pleasure to welcome and introduce Dr. Ruth Etzel. Dr. Etzel is Professor of Epidemiology at the Zilber School of Public Health at the University of Wisconsin in Milwaukee. She is no stranger to Alaska. She first came to Bethel in 1979 for a short-term stint as a medical student, and later would return from the lower 48 to Bethel just for the month of January to cover Dr. Ron Brennan's pediatric practice while he prepared to run the Iditarod. She adopted one of Dee John Rose sled dogs and raised it in Atlanta, Georgia. She moved to Anchorage in 2001 to take a position as Medical Director of Research at South Central Foundation, where she stayed until 2008. When she left Alaska, she moved to Switzerland, where she was Senior Officer for Environmental Health Research at the World Health Organization from 2009 to 2012. Dr. Etzel received the National Children's Environmental Health Champion Award from the U.S. Environmental Protection Agency in 2007 for outstanding leadership in protecting children from environmental health risks. And the new book that she co-edited with Dr. Phil Landrigan is the Textbook of Children's Environmental Health. Welcome, Ruth. We're so honored to have you as our guest presenter today. Would you like to go ahead and begin?
Thanks, Diana. Can you hear me?
I can hear you.
Okay, great. Well, I sure appreciate your kind introduction, and I did want to thank my good friend Pam Miller and Diana for all the work they do in ACAT. It's really phenomenal how much progress you've made, and thank you for the opportunity to speak today. I also want to thank my co-editor, Dr. Phil Landrigan, with whom I worked for 3 years to try to pull together all the information that we currently know about child health and the environment into this new textbook. And so let's proceed. I will try to give you the number of each slide as we move through, just so you can follow along with some of the text and some of the graphics that I've presented in the slides. And so let's move to slide number 2, which shows you the cover of our new textbook. This book was published in January of 2014, so it's barely 2 months old now, and it's actually the very first textbook designed so that we can teach students in schools of public health, schools of nursing, schools of medicine, more about the underlying science of children's environmental health. And of course, we hope that parents and community leaders also read it because we think the more people know, the more we can do to protect the next generation of children. So let's move to the next slide, which is slide 3. So why did we write this book? There are several reasons. First is that the environments that children live in and the patterns of childhood disease have changed profoundly over the past 5 decades. Even when I was doing my pediatric training, we were still dealing primarily with many of the infectious diseases of childhood, which have now, luckily, largely been eradicated. And pediatricians who start their training in the year 2014 are now dealing with many more chronic diseases of childhood than with the infectious diseases. We know that the prevalence of autism and asthma and attention deficit hyperactivity disorder, obesity, diabetes, and birth defects have increased substantially in children in the United States and many other parts of the world. And at the same time, some 85,000 new chemicals have been developed and released into the environment. And the World Health Organization has done some estimates and figures that about 36% of all childhood deaths around the world can now be attributed to environmental causes. So what do we mean by environment? Let's move to slide 4. And slide 4 asks the question, how much disease could we prevent by modifying the environment? And, of course, that depends on how you define the environment. Let's move to slide 5, because I think it's really important to define how the World Health Organization considered environment. Included in the WHO definition of environment are things like air, water, and soil pollution, radiation, noise, occupational risks, the built environment, agricultural methods, climate change, and hand washing. Now, factors that they didn't include are exposures to alcohol, tobacco, and drugs, any exposures that we get in our diets, interventions like bed nets, unemployment, natural disasters like earthquakes, floods, and tsunamis, and any person-to-person transmission. So what are the implications of this definition? Well, you'll notice that it's a very conservative definition of environment. But given the fact that it's conservative, this probably means that the WHO definition gives us an underestimate of what the true burden of environmental disease would be if we included all the things that are not included on the right side of the slide. So let's move to slide 6. And this is a map produced by the World Health Organization that attempts to show us the global burden of environmental disease. And it's pretty clear that the major burden of environmental disease is borne by people living in low-income countries. You can see that the darkest colors on the map appear here on the African continent, which harbors a huge burden of environmental disease, as you can imagine, from air, water, and soil pollution alone. Let's move to slide 7. This slide shows WHO estimates of how much disease could be prevented by modifying the environment. And the take-home message here is that the current best evidence is that 24% of disease could be prevented if we were able to modify the environment. So let me show you, starting on the left side of the graphic, you see AFR, which stands for the African region, and then AMR, which stands for the Americas, then EMR, which stands for the Eastern Mediterranean region, and then EUR, which stands for the European region, followed by SEAR, which stands for the Southeast Asian region, and finally WPR, which stands for the Western Pacific region. And you can see that there's variability in the amount of disease that could be prevented, varying from a low of about 14% to a high of about 31%. But the world average would be that about 24% of those diseases could be modified if we could modify, or could be prevented if we could modify the environment. Let's move to slide 8, I'm sorry. So slide 8 comes back to North America, and we want to focus next on the environmental diseases in North American children. And these, as I mentioned earlier, are predominantly the chronic diseases, and these diseases have been on the rise now for several decades. And I want to show you some of the trends that started to become evident about 30 years ago. Let's move to slide 9. This is a slide that shows asthma in the United States by age and by year from 1982 to 2009. You can see that back in 1982, about 3.6% of kids in the U.S. had diagnosed asthma. By mid-1990s, that had risen to 7.5%, and our most recent estimates from 2010 are that 9.4% of kids now have diagnosed asthma. Let's move to the next slide, which is slide 10. This shows the incidence of childhood leukemia. And again, you can see that leukemia increased in incidence from the 1970s through 2004. And this is despite the fact that the mortality from childhood leukemia has been declining. And that, of course, is the result of dramatically improved treatments for childhood leukemias. Let's move to slide 11. This is a graph that shows trends in birth defects, and this is for 2 birth defects. One is called hypospadias, and the other is called epispadias. You're probably familiar with hypospadias. This is a birth defect in which the opening of the tube that carries urine from the body doesn't develop normally. And you can see on this graph that this birth defect has doubled from 1970 to 1993, the period of observation here by the Centers for Disease Control and Prevention. Let's move to slide 12. This slide shows the incidence of testicular cancer. And this is a cancer primarily of young men, usually between age 15 and 30 years old. And the incidence of this cancer has more than doubled. And even more remarkable is that it's now occurring at younger and younger ages among men. Our next slide, slide 13, shows another alarming trend, and this is the trend in overweight and obesity. We've all seen this, just like on the cover of Newsweek, that the prevalence of overweight and obesity has more than tripled in American children in the last 30 years, from about 5% in the 1970s to about 17% today. And we see pretty remarkable disparities by socioeconomic status, by race, and by ethnicity. And what's particularly concerning is the really serious consequences for child health. We know that it can result in a more than 2-fold increase in overall mortality, a 4-fold increase in cardiovascular mortality, and a 5-fold risk of diabetes. Some people who have done the estimates have told us that terrible demographic consequences could result, because this might just be one of the first generations of U.S. children in a century to have a shorter life expectancy than their parents. Let's move to slide 14. I told you earlier about some trends in chemical production in the United States, and this graphic shows production of chemicals between 1945 and about 2007, and you can see pretty dramatic increases that have occurred during that time in chemical production. Let's move to slide 15. So there are now 85,000 chemicals in commerce in the United States, and most have not ever been tested for toxicity. Most have been invented just in the past 30 or 40 years, and of the 85,000, 3,000 are what are known as high production volume chemicals. And these are defined as chemicals that are produced or imported in quantities of more than 1 million pounds per year. And these would be then the synthetic chemicals that are most widely dispersed in our modern environment and therefore have the greatest potential for human exposure. But no basic toxicity information is publicly available for nearly half of these high production volume chemicals. And sadly, information on developmental toxicity is available for less than 20% of the 3,000 high production volume chemicals. And yet, CDC has done measurement of more than 200 of these high production volume chemicals in the blood or the urine, and they find them in virtually all Americans, including pregnant women, as well as in breast milk and in infant cord blood. So this has caused some concern. Let's move to slide 16, which focuses on developmental disabilities among kids. And you probably know that of the approximately 4 million babies that are born each year in the United States, about 10 or 15% are affected by developmental disabilities. And these include things like dyslexia, attention deficit hyperactivity disorder, which is now diagnosed in about 14% of American kids, mental retardation, and autism. And autism spectrum disorders are now diagnosed in 1 of every 88 American kids. And the trends are that the reported incidence of these developmental disabilities has been increasing. Let's move to slide 17. So 20 years ago, a very important report was issued by the National Academy of Sciences, and this report stated for one of the first times that children are especially and uniquely vulnerable to toxic chemicals in the environment. The report showed that kids had a greater proportion of exposure. For example, a 6-month-old infant drinks 7 times more water per kilogram per day than an adult. And we know that infants also have more exposure because of their normal exploratory hand-to-mouth activities. The report also stated that kids often have a diminished ability to detoxify many chemicals and to excrete them. And we know this is certainly true for chemicals like organophosphate pesticides. It also pointed out that kids have a heightened biological vulnerability because their organs are developing, and if a chemical if a child is exposed to a chemical during a period that during which organ development is occurring, it can have a profound effect on the development of that organ. And finally, this important report pointed out that kids have more future years of life in which to develop any consequences of early exposures to toxic chemicals in the environment. So the take-home message of this report was that children are not little adults. And this then has become one of the important messages of the children's environmental health movement. Let's move to the next slide, which is slide 18. So here are many of the ways that children are not like adults, and they are not little adults. First, they're short stature. They're closer to the ground, and so they can be at higher risk of inhaling any vapors that are heavier than air and that would therefore be in higher concentrations closer to the ground. And this is true for things like mercury vapor, which is heavier than air and settles toward the bottom, towards the carpet or the ground on which children may be playing. Kids also have increased food intake and metabolic rate. They can consume they can consume much more of certain things like milk. They consume much more fruit and often more vegetables than adults do. So, for example, like a 1-year-old child drinks 21 times more apple juice and 11 times more grape juice than an adult does. So this could make the 1-year-old at higher risk of ingesting any pesticide or any toxic chemical that might be present in these favorite foods. Kids also have altered excretion. As I said earlier, they are less able to detoxify and excrete some toxic compounds. They have a long shelf life and many more years in which to develop cancer or other potential effects of exposure to toxic chemicals. They have more hand-to-mouth activity, and this is absolutely normal exploratory behavior for kids, but it can also lead to significant ingestion of toxic substance that end up on kids' hands. They have more air intake, pound per pound, than adults. They have an increased skin surface area, and this can lead to greater dermal absorption of any toxic chemicals. And finally, they have ongoing organ development. Let's move to slide 19. And this is a slide that I borrowed from Dr. Jerry Nazenbenny, who many of you know from the Alaska Native Medical Center, and he took this during one of his trips to Africa. So it encourages vehicles to slow down to 20 kilometers per hour, and it says warthogs and children have right-of-way. Well, I look at this and I wonder, shouldn't we also be more cautious and give right-of-way to children when it comes to their exposure to toxic chemicals? Let's move then to slide 20. Slide 20 points out that children are not little adults, but also not all children are exposed to the same substances. On the left side are some potential exposures for a child in Philadelphia, and the issues there might be lead in their tap water, or pesticide residues in their foods, or mercury in their sneakers. But if we look at the right-hand side of the slide, we can see that the issues for a child in the Philippines could be dramatically different. In the Philippines, it may be an issue of no tap for running water. It may be an issue of death from drinking pesticides stored in a soft drink bottle, or perhaps exposures to mercury from its use in small-scale gold mining. And so because children live worlds apart, we need to be cognizant of what's going on in each child's environment and focus on the kinds of things that can make the most difference to the health of the child where he is. Let's move to slide 21. There is now strong and growing evidence of links between toxic chemicals and diseases among children, and this slide shows just a few of them. We now know that air pollution has been strongly linked to attacks of asthma among children, and we know that there are both indoor and outdoor triggers for these asthma exacerbations. We know that environmental exposures, such as ionizing radiation, exposure to diethylstilbestrol, pesticides, and benzene, have been linked to pediatric cancers. We know that with regard to endocrine disruptors, there's emerging evidence that phthalates may be linked to male reproductive problems, although this research is admittedly still in its early stages. And finally, there's a lot of evidence that neurodevelopmental disorders have been associated in many studies with exposures to lead, methylmercury, PCBs, PBDEs, phthalates, bisphenol A, polycyclic aromatic hydrocarbons, fluoride, solvents, organophosphates, and many other toxic chemicals in the environment. Let's move to slide 22. In the old days, just, 60 years ago, the womb was thought to be a very safe environment. That is until the early 1950s, when we finally recognized that toxic chemicals can actually pass through the placenta. This was not previously understood. But in the 1950s and the 1960s, pediatricians working in Europe began to see large numbers of newborn babies with a previously rare birth defect that's called phocomelia, and there's a child with phocomelia shown on this slide. The word phocomelia comes from the Greek. Phokos means seal, the animal, and melia means limb. And so the baby's limbs were initially thought to resemble a seal's flippers. And it turned out that virtually all of the babies had been exposed to thalidomide, which at that time had just been invented and was being used as a sedative and prescribed to women during the first trimester of pregnancy to help them with morning sickness. And we later learned after a lot of study that thalidomide is most harmful when taken between day 34 and day 50 of a pregnancy. And this, of course, is when the baby's limbs are being formed. And it was widely used throughout Europe, and over 10,000 cases of phocomelia were reported worldwide. Over 8,000 of those cases were actually in Germany. Luckily, there was a very careful scientist at the U.S. Food and Drug Administration who prevented it from being approved for any use in our country. And so we did not see the devastating effects of phocomelia in the United States as Europe did. Let's move to the next slide, which is slide 23. I want to talk about a paradigm shift that's occurring in child health. And so this graph shows the early thinking about child health, and early thinking focused primarily on the right side of the picture. Let's move to slide 24. So this early thinking focused on what we can do in the healthcare realm to improve child health. And this included many important treatments, such as treatment of meningitis with antibiotics and immunization against measles and mumps and rubella. But in those early days, there was very little attention to the left-hand side of the graph. So let's move to slide 25. And slide 25 shows us more recent thinking about the underlying determinants of child health. And this thinking demands that we not focus exclusively on the right-hand side of the picture, but that we turn our attention to the left-hand side of the picture, and we consider factors such as poverty and environmental degradation and poor nutrition and poor housing and things like insidious advertising that can actually lead children to do things that they would not do in the absence of advertising, such as smoking. Let's turn to the next slide, which is slide 26. So in this book, we actually try to address this new thinking about child health. There are 60 chapters by 85 different authors coming from 5 continents. And we start with introductory overview chapters describing the field of children's environmental health. And that's followed by some specific chapters on children's environments, such as the in utero environment, the home environment, the school environment, the green environment, the built environment. That's followed by chapters about specific environmental hazards, such as pollutants in water, sanitation and hygiene, hazardous waste sites. Then we have chapters on the major diseases of environmental origin in children. And these include the neurodevelopmental disorders we talked about earlier, things like asthma and allergies, and birth defects and childhood cancers. And then finally, the last set of chapters is about the prevention and control of diseases of environmental origin in children. And here we address the important public policy interventions that can protect children from toxic substances in the environment. And we also address some important global treaties that have an important impact on children's health. Let's move to slide 27. So remember that we used to think that the womb was a safe environment. So I want to take just a few minutes to discuss how our paradigm about the home has also changed. In the old days, the home was thought to be a safe environment, and it used to be thought that some of the major risks to health were outside the home. Some of the major concerns at that time were pollution from industrial operations and pollution from cars on freeways. And although those are still concerns, we have really dramatically shifted our concern because of studies that show that for some children, the major contaminants in the home environment can have an even greater impact than the contaminants in the ambient environment. Let's move to slide 28. So we now understand that the home, which I would think would be one of the places that should be the safest for a child, is often the source of some major risks to child health. And so we have tried to initiate a good environmental history. And clinicians taking an environmental history will try to learn about how safe the home environment is by inquiring about where does the family's water come from? What fuel do they use for cooking? Is there any smoking or tobacco use? Does the home have any water damage or mold? And are there any chemicals that are used in or around the home? And these questions can help the clinician to identify modifiable risks to children's health. Let's move to slide 29. So the reason it's important to inquire is that parents can see some risks to children's health, but there are also a fair number of risks in the home environment that are invisible. And one of the ones that's often invisible is the risk from mold. Mold is frequently invisible because it's hidden behind wallpaper or behind ceiling tiles or even behind furniture. And we know that it can occur in any damp indoor area, especially when there's cellulose, wood products, or wallpaper, or wallboard, and it becomes chronically wet. And it's been very conclusively linked with asthma and many non-specific symptoms among children. And also, studies have shown some rare conditions, such as lung bleeding among infants, have also been linked to certain molds growing in the home environment. Let's move to slide 30. So slide 30 shows one of those very rare events that called infant pulmonary hemorrhage. And you can see on this X-ray of a child's chest that it looks like there may be a pneumonia in this child's chest. There's an infiltrate, and it turned out that this child did not have a pneumonia. He had blood in his lungs, and that is what the chest X-ray looks like when a baby has had an acute pulmonary bleed. And some emerging data do show that these acute pulmonary bleeds can be linked to serious chronic water-damaged environments that have led to the growth of mold in the home that expose the child to mold through breathing it in through his lungs. It turns out that molds can produce very potent chemicals that are on the surface of the mold spore, and when a baby breathes it in, the capillaries of the lung are very fragile and may burst and cause lung bleeding. So this is important for parents to know about because some cases of acute pulmonary hemorrhage can look exactly like cases of sudden infant death syndrome, or SIDS, which is still a problem that defies our understanding. Let's move to slide 31. This just shows you some of the chemicals that can be produced by molds. And I talk about this largely because we don't want anybody to think that the only chemicals that we need to be worried about are chemicals that are synthetic and produced by man, because these chemicals are chemicals that are produced by organisms, and yet they're associated with many both acute and chronic health effects. And you've probably heard of the chemical aflatoxin because it's been linked to liver cancer and is fairly widely appreciated. But some of the other mycotoxins on this list aren't well understood, and most doctors don't even learn a thing about them in medical school. But it's important to know that they can be produced by household molds and can cause problems for children. Let's move to slide 32. Many of the problems in kids are related to the airway, if that is the route through which children are exposed. And they can include airway irritation or eye irritation. They can include headache or difficulty in concentration. Reactions we talked about earlier, such as asthma or rhinitis. In kids who are suffering from cancer and are thereby immunosuppressed, these molds can result in severe systemic infections. And we mentioned earlier that in normal kids who breathe in spores in their home environments, it can result in pulmonary bleeding. Let's move to slide 33. So what do? One of the important messages is that water damage in a home needs to be cleaned up immediately. But cleaning up the visible mold is often not enough. Sometimes you have to go behind the wallpaper. Sometimes you have to go behind the dresser and find that hidden mold that might be causing problems. Mold requires water, and if you clean it up once, don't find out where the water is coming from, it may well recur. And so it's really important to fix the source from which the water is coming. Next slide is slide 3.
Dr. Etzel?
Yes?
This is Diana. I just wanted to give you the 15-minute warning.
Oh, thank you.
Warning is not the right word, but just wanted to let you know where you are with time.
Thank you very much. I was going to talk a little bit about indoor smoke, but I believe that this is a problem primarily for people in developing countries, and so let me just skip quickly over 34, 35, and 36, and let's go to slide 37, which talks about the growing epidemic of tobacco use. And I just wanted to mention that just as we are concerned about both man-made and natural toxic substances in the environment, we have to be concerned about the continued rise in smoking worldwide and the secondhand smoke exposure of children. This slide shows that by 2025, there'll be about 1.6 billion smokers in the world. Let's go to slide 38. And about 700 million kids, which is half of the world's kids, are breathing air polluted by tobacco smoke, particularly in their homes. Let's move to slide 39. And this shows the burden of disease estimates from WHO, which shows that exposure to secondhand smoke caused approximately 166,000 deaths in kids in the year the estimates were done, which was 2004. And you can see that it varies depending on what part of the world the child lives in. And one of the sad things is that policies designed to eliminate cigarette smoke, both in work and public settings, are very useful interventions, but only 7.5% of the world lives in areas with laws prohibiting cigarette smoking in work and public settings. Let's now skip just a few slides forward because I want to get to some success stories. Let's skip forward to slide 47. So slide 47 takes us to one of the huge success stories of public policy, and one that you probably know a little about, but I want to reinforce how important it is because it shows what a concerned group of people can do when they bring to bear public policy interventions to reduce children's exposures. So slide 47 is about lead poisoning, which accounts for a great deal of the global burden of disease. We figure that about 1% of the total global burden of disease from lead exposure comes from lead exposure, and most of it affects kids in developing countries, where we think that as much as 15 or 20% of all mental retardation could be caused by exposure to lead. So let's move to slide 50. Because this is where we come to reasons for hope. I think it's so important for us, people who care about children's health and the environment, to remember how effective environmental interventions can be. So the environmental intervention that we're so proud of and that is a model for so much future action is the success story of getting lead out of gasoline. Let's move to slide number 51. So 51 shows that at the end of the 20th century, many developed countries had already phased lead out of gasoline because they realized it was a terrifically efficient way to disseminate lead to all members of a population through the air. But few developing countries had done this. And so, led by the United Nations Environment Program, targets were set for just eliminating lead from gasoline altogether. Let's move to slide 52. So slide 52 shows the campaign to phase lead out of gasoline, and it began in 2002. It had more than 120 members. There were doctors, parents, scientists, government, industries, international organizations, and they developed a small clearinghouse in Nairobi with only 12 staff. But take a look at what 12 concerned people with a whole array of others behind them were able to do. Let's move to slide 53. So slide 53 shows the world map, and you can see that the countries in light colors still have leaded gasoline, or some of the other light colors have no known lead or unleaded gasoline, so that their status is unknown. So let's watch Africa, and let's move to slide 55. On slide 55, you can see the progress between the year 2002, when the campaign started, and the year 2005. Check out what's happening in Africa. Countries are getting rid of lead. Now let's move to slide 56. That's for the year 2006. And you can see that by 2006, just about all of the African continent has gone unleaded. Let's move to slide 57, and that's the status 2 years later. Again, you can see remarkable progress with fewer and fewer light-colored countries, and in fact, you can see that Central Asia now has more unleaded gasoline. Let's skip ahead to slide 59, and in 59 you see that 3 countries are still using leaded gasoline, and 6 are using both leaded and unleaded gasoline. And then finally, slide 60, which is our most recent estimate, which shows that really only 3 countries are using leaded gasoline, and only 3 more are using both leaded and unleaded. And so this is what I consider to be a remarkable success story about what concerned citizens getting together can do. And let's skip to slide 62, which shows that this slide shows about 17 different studies from 14 countries showing remarkable reductions in blood lead concentrations in kids following the phasing out of lead in gasoline. So it's a huge success story. And I think it offers us reasons for hope for many other toxic substances in the environment. I have reason for hope because I think environment, which was an invisible issue, is becoming more visible. More people are taking action. Let's move to slide 64. The other alternative when faced with these environmental toxicants and children's exposure is to do nothing. But I don't think that's an option that many people on this call would choose. And slide 65 shows another success story. After the banning of DDT in Sweden, you can see dramatic reductions in the amount of lead in breast milk in women in Sweden. And finally, I would like to skip to slide 67, which is one more success story, which is the benefits of our own Clean Air Act amendments of 1990. You can see on this slide that the direct benefits of the Clean Air Act amendments significantly exceeded their direct costs. Direct benefits were $2 trillion, and direct costs were only $65 billion. And the economic welfare and the quality of life for Americans were dramatically improved by the passage of the Clean Air Act amendments. So I believe there's reason for hope. I believe our book has many other examples. And I guess I'll end by saying that we think that it will lead to much more advocacy. Advocacy is already happening in many, many countries, but we do hope that it will increase and that parents and communities around the world will band together to work towards an environment in which future children will have less exposure to toxic substances. So thank you very much, and I'd be glad to have some discussion with people on the call about the primary concerns that bring them to the call.
Thank you so much, Dr. Etzel. And I should point out that slide 69 shows ways to order the book that is co-edited by Dr. Etzel and Dr. Phil Landrigan. So make sure to look towards the end of the presentation as well. And also, Dr. Etzel and Phil Landrigan are the featured speakers for a Che Cafe call tomorrow, sponsored by the National Collaborative on Health and the Environment at 10 a.m. Pacific time. And before we go to the discussion, Ruth, did you want to say anything about that call, what the content focus will be for people who might be interested in joining?
Oh, sure, that'd be great. So our call tomorrow is a call to basically introduce the specific chapters of the book. We give a few examples from various chapters of the book. We talk about the users and how they might utilize the book to work towards social and environmental changes. And, I guess that's it.
Okay, great. So as Dr. Etzel said, we would like to invite you now, the people on the call, to say a little bit about, what brought you to the call, what you're interested in, ask questions, and have some discussion. So we're going to open the lines for your questions. And if you'd like to ask a question, please press *2 to unmute your line. Please be sure to press *2 again at the end of your question so that we can reduce background noise. And we'd appreciate it if you could state your name and affiliation, where you're from, if you're with an agency or whatever you'd like to say. And we ask that you try to be brief so we can get to a few questions before the end of the hour.
Hi, my name is Jane Palmer, and I'm with North Central Public Health District in the beautiful state of Oregon. And I'm definitely a public health person through and through, and focused primarily on maternal-child health. And so am excited that there is work going on in healthy environment and healthy community. One of the questions I have for you is, are there any really high-level policy or system changes going on addressing the fact that those 80,000 chemicals have absolutely relatively no toxic testing, or, unlike the FDA? So thank you for that.
Yes, thank you for that question. And yes, the answer is absolutely. Many organizations are trying to work on new safe chemicals legislation at the national level to remedy the situation where chemicals are released without what we consider to be adequate testing. Frank Lautenberg, who recently died, was one of the major champions of reforming the toxic chemicals legislation, and many people are carrying it forward after his death in order to enact legislation that would be more protective of children.
Thank you for that question.
Mm-hmm.
Anyone who'd like to ask a question?
This is Mansell Nelson with Northern Arizona University, and I work on several projects, especially indoor air quality in tribal communities. You skipped indoor smoke because you thought that perhaps it was less applicable, but many of the tribal audiences I work with, wood smoke is of concern issue. There's a lot of reliance on wood stoves, and of course, we hope the situation is much better than we find in China and some of the other countries. But some of the research I've been doing indicates that this is still a prevalent problem amongst many of our tribal communities. Could you comment a little bit more on that? Thank you.
Well, thank you for that, because I actually think it is one of the more important problems worldwide, and I apologize for having skipped it. I didn't realize that I was taking up so much time. But yes, for the world, it is absolutely right up there as one of the top environmental problems, and I'm so glad you're working on it. I find it's one of the areas where there's actually been the most progress, like in the last 10 years, because, first of all, important international initiatives like the Global Alliance for Clean Cook Stoves have been formed, and even folks like Hillary Clinton have thrown their support to these kind of global alliances to try to figure out ways of switching to cleaner stoves and also switching to cleaner fuels, because as I was going to mention, these kinds of interventions are known to be effective. We've got really good data showing switching to cleaner fuels results in a 7-fold return on investment, and a switch to improved stoves results in anywhere between 25 to 60-fold return on investments. And then we've also got to consider that it's very good when we're looking at issues like pressure on our forests and greenhouse gas emissions. And so there are all kinds of reasons to highlight important work on reducing indoor smoke exposures. I congratulate you for working on it. It's such a huge problem for kids because of the way it leads to such high particulate levels in the air. And this, of course, not only causes asthma exacerbations, but I think the recent data are pretty convincing that it can actually cause asthma, first episodes of asthma. And so there's a lot of reasons to try to prevent that first episode from happening by reducing exposures to particulate from wood stove use.
Thank you.
Hello, this is Nurse Melody over in Kenai, Alaska with our state public health. I have a quick question about when we're assessing individuals in the clinic, because we ask them generalized questions about smoking and having wood stoves in the home and drinkable water, but are there more specific questions that can be more symptom-related rather than just looking, because most people will say, yeah, my water's fine, or our wood stove isn't a problem?
So if I understand your question, you would be looking, for example, for questions that could be integrated into a visit of a child who comes in with wheezing or asthma, that kind of thing?
Yeah, just some general environmental health questions that might be easy to add into the clinic appointment.
Sure. Well, there's been quite a lot of work done on specific environmental history taking, especially around the issue of childhood asthma. There's also been quite a lot about the issue of childhood lead. And one of the organizations that has been taking the lead in this history taking is the National Environmental Education Foundation, NEEF. And I'd suggest you take a look at some of the good questionnaires that they have on their website. And I know that they are continuing to develop this kind of work so that clinicians can have a handy page to pull when they see a patient with what they think is an environmentally related disease, to try to focus in on the key chemicals that we think might be most likely to be related to that environmental disease. The other group that has done quite a lot of work on this is the American Academy of Pediatrics through their Council on Environmental Health. They have also developed some really nice home inventories, as well as specific questions that they think pediatricians and other clinicians who care for children ought to consider including when they see a child with a disease that could be linked to the environment. And I can provide both of those to ACAT so that they can distribute them if you would like.
We'd be happy to do that. Do we have any other questions?
Yes, this is Joyce Young. I'm a naturopathic physician in Cape Cod, Massachusetts, with an area of expertise in environmental medicine. I was a member of the American Academy of Environmental Medicine, and I was very interested in your comment that most MDs are not trained in environmental medicine, actually, or nor nutrition. And the American Academy of Environmental Medicine had actually sent invitations to all the medical schools in the entire United States to send faculty free of charge to their conferences. And the medical school sent no one because they said they had more important things to teach. Would you like to comment on how do you change the paradigm within Western medicine, which is basically the prevailing paradigm? It's not naturopathic medicine because we are well trained.
Boy, that's a really tough question. One of the ways I think is pretty important to point out is, and just to go back to the World Health Organization's estimates of disease prevention. So, and that's actually why I started with that, because very few doctors, if asked how much disease could be prevented by modifying the environment, would come up with anything close to the estimates that WHO provided. I guess that if you would ask a doctor how much could be prevented, they might say, 2 to 5%, because at least when I was training at the University of Wisconsin, it was thought that the proportion of disease that could be prevented was very small. And it's only after the World Health Organization, the largest organization devoted to prevention of disease in the world, it's only after they did a very careful study of actually how much could be prevented and came up with this conservative estimate of 24% that many people woke up and said, well, that is a different story. That's a lot more than 2 to 5%, and that's worth paying attention to. And because of that, we now have not as many as I'd like, but a few training programs devoted exclusively to helping doctors become specialists in, how to be able to recognize, diagnose, treat, but moreover, prevent diseases linked to the environment. So I applaud you guys for continuing to do this. I recognize it's a big deal. And I think you should try to use the WHO paradigm. 24% is the best conservative estimate of the amount of disease that could be prevented by modifying the environment.
If I can make one more comment, there's a lot of information right now about the benefits of integrative medicine, the best of both. And I think that this is a really good example of the best of both because naturopathic physicians have a really good grasp on a lot of this prevention. Thank you so much. It was wonderful.
That's an excellent point, and I hope you can get more people to work together with you.
Thank you.
Thank you, and I'd like to know, Dr. Etzel, I'd love to take one more question, and I'm just wondering if you can stay over just a couple of minutes or if you have another engagement.
We could do one more. I have just about 2 minutes left.
Okay, then I think I will go ahead and, well, actually, you can get off the line after we take that last question, and I'll do the wrap-up after you.
Okay.
For the other announcements and whatnot. So let's go ahead and take one more. Or not. Okay. I thought I saw someone trying to get in. So I'll go ahead and just wrap it up. I want to thank you again, Dr. Etzel, for your presentation today and for all that you're doing to promote environmental health. Let's see here.
Thank you, Diana. Okay, bye-bye.
Let's say that this is really important. This is Rosemary at Dongarok. I missed the mute button. But I hope that we get further discussion into how we can tie this process into local community meetings in the health assessment and ways that we can allow some of these activities that are promoting changes in our lands and waters for energy development to have other areas consider the health impacts they're creating to us and areas that live where these activities are occurring. But I really think all this discussion information, and I want the book, and great for all the work.
Thank you, Rosemary, for your comment, and perhaps we can continue that conversation outside of the call, since Dr. Etzel does have to get off of the call. So I'm sure that ACAT would be happy to be in touch with you to discuss some possibilities. We'll be sending a follow-up email with a link to the recording of today's call and a link to the action to take action in support of the Toxic Free Children's Act. Also, you won't want to miss our next call, which is on Tuesday, March 25th, with Dr. Tracy Woodruff, who will be discussing exposure to toxic chemicals among pregnant women and children, the role of prevention. Please note that this call will begin at 3 p.m. Alaska time and is on a Tuesday, not our normal Wednesday. So again, that is March 25th. And Alaska Community Action on Toxics is also hosting a series of public events with Dr. Woodruff on Tuesday, March 25th in Anchorage, and on Wednesday, March 26th in Juneau. Her talk in Anchorage will be from 7 to 9 p.m. at the Fine Arts Building on the UAA campus and is co-sponsored by the Departments of Biological Sciences and Health. And in Juneau, she will be presenting on March 26th at a lunch and learn with Alaska legislators and their staff in the Capitol at noon. And an evening public talk will be at 6:30 p.m. at the Goldtown Nickelodeon Theater in downtown Juneau. You can visit our website for more additional event details. And remember, you can support these calls with your tax-deductible contribution to Alaska Community Action on Toxics via our website. If you have additional questions or comments, feel free to contact us. Again, the phone number is 907-222-7714. You can email me at diana@akaction.org. And thanks again to everyone who participated, to you, Dr. Etzel, for your time in preparing your presentation and for your incredible work. And have a wonderful day, everyone. Thank you.